our 1-year and 3-year outcomes for lung transplant patient survival are typically in the top 5 nationally. There isn't a particular secret sauce. It's that whichever combination of staff are involved with a given patient, if everybody's strong, then every possible combination is good. So it doesn't require a specific team to be on call or to address the sickest of patients.
By having a strong multidisciplinary team, really we can wrap all the resources around the patient when they come here to see us, so that they feel like they're being taken care of, they feel like they're part of our family, and they're getting the absolute best care and best outcomes here at our program.
We have physicians, surgeons, nurse coordinators, financial counselors, dietary professionals, physical therapists, pharmacists, social workers, psychologists, all those people. Palliative care, we have a palliative care team as well that is involved in assessing these patients, and then we come together as a multidisciplinary group.
One of the things that we try to do at this program is take advantage of donors that might not otherwise even be considered for use in transplantation. One of the ways that we're able to do that is by the use of ex vivo lung perfusion, a technique where explanted donor lungs are put on a perfusion circuit and ventilated for a period of about 3 hours, during which time we're able to evaluate pretty much everything about the way lungs function to decide if those lungs are going to in fact be suitable for transplantation into a recipient. The other thing that's very exciting about lung transplantation now is we're starting to get to the point where additives can be placed into the solution that's used to perfuse donor lungs during ex vivo lung perfusion. With this type of specific molecular biology engineering, we're going to be able to not only maintain and evaluate lungs outside of the body, we're going to be able to improve them. That is going to have such a substantial effect on the potential donor pool. We consider patients who've had prior heart surgery, prior lung surgery, including lung transplantation. We've had patients transferred in from other institutions that offer lung transplantation but simply didn't think that they were able to offer it to the particular patient under consideration. Some patients find themselves in a unique situation in that they have both coronary artery disease and end-stage lung disease. And some programs would consider those patients not candidates for lung transplantation. But here we're able to utilize a unique robotic approach to mobilize the left internal mammary artery and use it as a bypass conduit and still offer bilateral lung transplantation through small anterior thoracotomy incisions. At our institution, the folks that do lung transplantation surgery are also cardiac surgeons, and so we're able to draw on areas of our expertise from both disciplines in order to offer the most that we can to a patient who may face issues with cannulation or the need to be on extracorporeal support at the same time as their lung transplantation.
There's really more patients available than there are donor organs, and so patients often become quite ill before they are able to be listed and successfully get a transplant. And so they're quite deconditioned, weak, experience significant weight loss, all of which present challenges to preparation for them to go through a very significant surgery like lung transplantation.
So in a typical lung transplant operating room team, you're going to have an anesthesiologist, a surgeon, a perfusionist, a first assistant, a PA, a nurse, and a scrub tech. All of them trained differently, all of them coming to an operation at a single point of care to take care of a patient for the best outcome. Our turnover rate currently is between 2% and 3% for our team. I think nationally it's around 30% to 40%. What we've tried to do is keep our focus on the patient and the care and the gift that has come from the one that passed and the care that we're going to provide to our patient. And our teams get to see the outcomes. And the outcomes are best in nation, 1 year, best in nation, 3 years now.
Our work mainly focuses on 2 areas. One is collecting transplanted lung, explanted lung from the hospital. We collected about almost 200 cases post-lung transplant explant. And also we collect biopsy from post-lung transplant monitoring program. We use the samples to do translational research and try to find a new therapy.
An exciting area is the 3D printing of scaffolding of the organ, like the lung, and then seed that scaffolding with the patient's own stem cells that can populate that scaffold to basically create an artificial lung.
If donor lungs are stored at 10 degrees centigrade instead of much colder on ice, you can actually go quite a bit longer, and so that's allowed us to do a lot of our surgery by the light of day when the team is fresher. And we're currently in a multinational, multi-center trial looking at outcomes of donor lungs stored at 10 degrees rather than 4 degrees.
An important and unmet need, definitely in the field, is better refinement in the drugs that we're using to prevent rejection, yet not get too much infection and malignancy and kidney failure, which is the long-term problem in a lot of patients. So we want to think about more than just 1, 5, and even 10-year survival. We really want to look at long-term survival of the whole body, not just the graft.
At the moment, we're the busiest lung transplant program in the state of Michigan, and so to pair that with our very high-risk population of recipients and our extended criteria for accepting donor lungs has been extremely rewarding.
Thanks for watching, but now an important disclaimer. The content of this video is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Viewers should not disregard or delay in obtaining medical advice for any medical condition they may have and should seek the assistance of their healthcare professionals for any such conditions.